The New Jersey Center for Tourette Syndrome and Associated Disorders, NJCTS, and its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now I'm going to turn over the introductions of our speaker to Martha Butterfield, the Program Coordinator of NJCTS. Marty?
Thanks, Kelly. And I'd like to welcome our audience and introduce everyone to Dr. Michael Seyffert. Dr. Seyffert is a pediatric neurologist at the New Jersey Neuroscience Institute at JFK Hospital in Edison and acting director of their Sleep Medicine Center. He is also assistant professor at Seton Hall University School of Graduate Medical Education in South Orange, New Jersey. Dr. Seyffert received his MD from the Technion Institute in Israel and has completed residencies in pediatrics, neurology, and sleep medicine. He's done research in functional neuroimaging of ADHD and related disorders, including Tourette, obsessive-compulsive disorder, and pediatric sleep disorders. His specialties are pediatric neurobehavioral problems such as ADHD and autism, as well as sleep disorders. He was recently featured on WNBC speaking about sleep problems in children. As a consultant, Dr. Seyffert has helped to shape the curriculum of Da Vinci's Child to reflect the latest neuroscience research that suggests that music and movement can cultivate awareness and control, as well as social and emotional intelligence. He has co-authored articles on the organizational, time management, and planning behaviors of children with ADHD, as well as rhythmic movement disorder associated with respiratory arousal. It is with great pleasure that I turn tonight's presentation over to Dr. Seyffert.
Thank you very much, Marty, for that kind introduction, and welcome to everyone to this webinar discussion of Tourette syndrome and associated daytime and sleep behaviors. I'm very excited to be talking about sleep. I'm quite passionate about it, but as passionate as I am about it, it's as a sleep physician, I'm somewhat humbled that no one really knows what sleep is, the function of sleep. Yet we all accept that sleep is an essential part of our human biological makeup. And we recognize this because the lack of sleep has such dramatic consequences for our daytime behaviors. As we see in this, hopefully this is working. Okay, trying to switch slides here.
Try moving your mouse to the left side of the screen at the bottom. Nope. Up. I'm sorry, left side of your slide at the bottom. Okay. There should be... There should be some kind of hidden left and right arrows. Nope.
I'm looking.
All right. Can you click on? No, it's not on the taskbar.
Okay.
Can you click on your slide there and then use the arrow keys on the keyboard? Or don't you have arrow keys on that?
I got arrow keys, and they were working before when I did the run through.
Okay. There you go. Down at the bottom, you see, oop, there you go.
Yeah, I see now. I see them. Sorry about that. So, a little humor, as we see in this cartoon of Garfield, who looking quite sleep deprived. We know that we can do some strange things, and here we see Garfield kissing his nemesis, Nermal. So, just briefly, I want to kind of review 4 basic topics. First, the nature of the link between daytime and nighttime sleep behaviors. 2, to overview the developmental sleep needs that our children have. 3rd, to review common childhood sleep and some daytime neurobehavioral problems that are associated. And finally, to discuss a common sense approach to diagnosis and treatment, which will include medications. Well, so we're talking about the lack of sleep or sleep deprivation, and we know that that's an increasing concern to parents, teachers, and physicians alike. Sleep problems, we know from the literature, is found in about 1/3 or more of our kids. The problem, though, is that those needs are different depending on the developmental stage of the brain. Now, socially, we're understanding that for a variety of reasons, our kids are getting less sleep. They're banning naps at school. There's increased access to technology. Some of our kids are texting at night. And the result is that children and adolescents are increasingly deprived of sleep. This sleep deprivation, in turn, can lead to a variety of neurobehavioral symptoms like hyperactivity, inattention, problems focusing, worsening tics. And as a very bright person in the field of medicine, a psychiatrist and pediatrician, Professor Ronald Dahl notes, and I want to quote this, and this is probably the only quote I'll have, but it's important. Sleep is the other side of the behavioral coin in that sleep disorders may mimic or worsen psychiatric disorders. This is a very important quote, and we'll come back to this throughout the talk. Now, what is the function of sleep? I alluded to that before. Research into the neuroscience of sleep continues. Evolutionarily speaking, we think that sleep may have been important to avoid predators. Other theories state that sleep is important because when we're asleep, our metabolic rate is low, and therefore it's important for energy conservation. Other scientists believe that sleep has a restorative function for our body and brain, and they cite the fact that sleep can help to consolidate memory for learning or help with emotional regulation. But whatever sleep is, it's complex, it's mandatory, and it's a cyclical process. And when we don't have enough sleep, it has major negative consequences for our kids. The cyclical process of sleep and wakefulness is controlled by circadian rhythms. Circa diem, around the clock, around the day. This sleep pacemaker or timer is located in the region of the brain called the hypothalamus, specifically a region called the suprachiasmatic nucleus. Now, the details aren't important, but what is important is that this biological clock regulates our 24-hour sleep-wake cycle. And we start off a wakefulness, and we transition into light sleep, stages 1 and 2, and then slow-wave sleep. And then we go into rapid eye movement or dream sleep. And we do that about 5 times in the night, in cycles about 60 to 90 minutes. Now, on a bigger scale, shifts in the circadian rhythm we see in the teenagers who, because of this changes in the rhythm, are forced or being more likely to sleep later during the night. The next slide, which changed, let's understand a little bit more about the neuroscience of wakefulness. We've known for 40 years that there are specific types of cells in the brain called the reticular activating system, and they're in the deep parts of our brain. But they project throughout the thalamus into the cerebral cortex to allow us to maintain wakefulness. What people don't understand is that these same nuclei, the raphe nuclei, which contains the neurochemical serotonin, or the locus coeruleus, which contains norepinephrine, or the ventral tegmentum, these are big names, but these neurochemicals, dopamine, norepinephrine, serotonin, are responsible for maintaining our wakefulness, arousal, and our behavior. And this is the link between daytime mood and nighttime sleep. The neuropsychological impact of sleep problems has been an area of active research. And what we know is that if you don't have enough sleep, you feel tired. And when you feel tired, your reaction time is down. And you're not able to remember things, and you have poor memory consolidation. And this leads, again, to increased accidents and behavioral problems and irritability and mood issues. And what's interesting is that for our kids who are overweight or obese, inadequate sleep can even cause worsening obesity. This graphic here, I want to spend just a little time on, and to really say that most sleep problems in children are due to one of these 3 reasons. Children aren't getting enough sleep, their sleep is poor or disrupted, or that they have a bad timing or inappropriate amount of sleep. And all of these 3 factors can lead to the same common pathway, which is excessive daytime sleepiness. this graphic shows different sleep problems. And at the core, I want you to imagine this thing called sleep deprivation. Any of these sleep problems, any or all of them, can lead to sleep deprivation. So in the next slide, we see that sleep deprivation must be taken seriously. I'm trying to convince you of that. And why am I trying to convince you of that is when you look at the science and we do the science, we find out that sleep deprivation has the same negative performance effect as drinking alcohol. There are many daytime risk factors, and some of which the parents are not even aware of. Our children with asthma, allergies, even ear tubes can have an increased risk for sleep apnea. Gastroesophageal reflux, also the same risk of sleep problems and sleep deprivation. I want to pause for a second and then talk from a different perspective, a neurodevelopmental perspective and not a neuroscience perspective. Every stage of our child's development has different sleep needs. For infants, they may spend 50% of the time in sleep, about 16 hours. For toddlers, the terrible twos, sleep ranges from 12 to 14 hours a day. And most give up their second nap by 1 year of age. What's interesting at this stage is the separation fears a lot of parents talk about. This is notable, and what's notable about this is the associated bedtime resistance. Mommy, I don't want to go to sleep. The crying, the tantruming. This can be improved by the use of a transitional object like a teddy bear. This can help smooth out the transitions, and some parents even go so far as to go to Build-A-Bear and include a little recording of the parent's voice to help soothe the child and help them to learn to make that transition by themselves. At ages 3 to 6, kids need a little bit less sleep, around 11 to 13 hours of sleep. However, what is interesting is that the national polls, 1,400 parents took this poll, and they showed that their kids were only sleeping around 10 hours of sleep a night. What's important is that sleep problems at this age may tend to be chronic. By school age, sorry, I think I jumped the gun there. By school age or middle childhood, the total sleep time ranges from 9 to 11 hours. And the chronic sleep and daytime behaviors are now leading to insufficient sleep. Parents, though, can play an important role here. They need to reinforce a bedtime routine. It needs to be consistent, 45 minutes, 30 to 45 minutes, a wind-down period. And if you're seeing that your child is having problems, if you're seeing that they're snoring or they're having problems maintaining sleep or coming and saying they can't sleep or having academic problems, then these issues need to be addressed. The final developmental period, which is a very vulnerable period, is the teenagers. For any of those parents who have teenagers, we recognize that there's a combination of those biological and social changes, the access to technology, that place special demands on teenagers. And yet, while teenagers need at least 9 hours of sleep, most of them are getting less than 7 hours of sleep. Adolescence is also a time of increased risky behaviors, experimentation, in some cases substance abuse. And if you add on to that sleep deprivation, you can see the increase in impulsiveness, irritability, and even aggression, which complicates things. So I want to review and step back and say, now that we've kind of given the overview, what are the common pediatric sleep disorders we can talk about? Most of the common sleep disorder, the most common rather sleep disorder, is behavioral insomnia. And insomnia, I mean a difficulty initiating or maintaining sleep. This affects up to 30% of children. And it usually starts in the period of the toddler, where bedtime resistance or co-sleeping starts. And as children become used to taking the reins and telling their parents when they want to sleep, that these sleep problems persist. In addition, problematic sleep movements or sensations that may start off as growing pains may herald the diagnosis of restless leg syndrome. These can affect up to 17% of children. In addition, up to 15% of children may have some rhythmic movements such as head banging or body rocking. Parasomnia is a common sleep complaint. Typically, parents are terrified as their child wakes up confused, not recognizing them, looking straight ahead. They may be sweating and unconsolable. And while these are dramatic, they tend to subside by adolescence and tend to not require intervention. The last two items, sleep apnea affects up to 3% of children. However, up to 20% of kids are snoring, and even snoring can disrupt sleep and lead to sleep deprivation. Finally, narcolepsy is found in between 2 and 14% of children, and both sleep apnea and narcolepsy are found very commonly in kids with attention deficit hyperactivity disorder. So this graphic shows, oh, I just missed it, some of the common cognitive, sleep, motor, and mood problems. And as healthcare providers, teachers, and parents, we need to understand the interweaving of these problems. So let us review in some detail the more common of these cluster syndromes. But due to limitations of time, I'm only going to focus on rhythmic movement disorder, restless leg syndrome, head banging, insomnia, parasomnia, and sleep apnea. This graphic is taken from Dr. Yunus. I want to thank him. He's from the University of Washington. And why I like it is it shows the association between Tourette syndrome or tics and obsessive compulsive disorder and anxieties. We know that there's a genetic linkage between Tourette's and OCD, and we commonly see this in families. We also know, thanks to work with people like Barbara Coffey at the NYU Child Study Center, that ADHD is also commonly found along with Tourette's and OCD, and that these cluster syndromes, the ADHD, Tourette's, and OCD, can make significant impact in terms of insomnia or difficulty falling asleep or staying asleep. Now, from a population perspective, restless legs syndrome, periodic limb movements, and the ADHD, Tourette's are often associated. We've established that. And I want to convince you that the insomnia that a lot of the parents say, well, you're giving my child medication, that's the reason. Well, in 30% of children who have attention deficit hyperactivity or Tourette's are not on medication, still have problems falling asleep. In addition, despite the fact that they have ADHD and or Tourette's or OCD, they still may have snoring and other parasomnias which are also negatively impacting their sleep. Sorry, this is jumping the gun here. Given the significant overlap between these sleep and daytime behaviors, I'd like to highlight a common disorder that we find in some of the neuropsychiatric populations, specifically autism and cerebral palsy. This next slide shows a 7-year-old with autism and severe nocturnal head banging. The Latin is very fancy, jactatio capitis nocturna. But this child hit his head 250 times per hour. Now, while most head banging is self-limited and does not require therapy, this child ended up having to be treated. And the choice of medications varies, but can include clonidine, guanfacine, or clonazepam. Pretty dramatic. The next slide.
To the right. That's back.
Sorry.
Just click on it again. Nope, where you were. Slide your cursor to the right. One more. Click. It should highlight.
All right, gotcha. Okay.
There you go.
This next video shows a 12-year-old male with Asperger disorder, severe complex motor and vocal tics, teeth grinding, and rhythmic movements disorders. Now, I want the audience to look at this picture of this child in sleep, and he's asleep. And yet, you have these brief, kind of involuntary, repetitive movements, stereotype movements, which during the daytime we say might be a complex motor tic. Now, as the video goes on, he has hand banging, reaching, and leg rolling movements, and we can see that better in the next video, which I'm going to shift to. to convince you of the constellation of these rhythmic movements.
Should be,
Okay, there we go. The next slide, we see the classic leg rolling and periodic limb movements. You can see that this right leg comes up. And then we have the rhythmic movement, both of the right leg and the right arm, to include reaching movements. Now, this child had a sleep efficiency of about 45%, which means he was sleeping less than half the night. And the other half of the night, he had these complex movements, was definitely impacting his sleep. It was interesting to note that his Yale Global Tic Severity Scale was severe, as well as was his Yale Brown Obsessive Compulsive Scale. And despite being treated pharmacologically, we were having very variable success with his sleep behaviors. So these are important issues to consider. So what I'm trying to convince you is that restless leg syndrome is a disorder that we have to be concerned about. It consists of sensory motor symptoms, uncomfortable sensations, which can be described as growing pains, stiffening, tightening. It tends to occur when children are not moving around or immobile, worse in the evening. They feel better when they move around. And in order to meet criteria in childhood, the child has to be able to explain this in his own words. Now, there are alternative criteria to meet this. If the child can meet all the 4 essential adult criteria, but also have excessive sleep disturbance and have a periodic limb movement index of greater than 5 movements per hour, then they also meet criteria. Now, it's important to separate what I term primary from secondary restless leg syndrome. Primary means that there's a genetic component, and that occurs in about 50% of cases. This is an autosomal dominant disorder. Secondary is very common and may relate to primary iron deficiency. So the take-home message for the primary care physician is that getting the iron percent saturation, the ferret and the CBC, may be important because it impacts on how we treat kids. We start off with supportive care. Sorry, let me back up a second. Before I get into how we treat, I want to talk about some of the things that can be confused, some pictures that can confuse us with RLS. Leg pains, joint pains may suggest RLS, but it may suggest arthritis if there's swelling and inflammation. We have to put this on our differential diagnosis. Akathisia is a constant internal sense of movement related to drug effects, such as atypical neuropsychotics, antipsychotics, or more typical antipsychotics are common. Leg cramps, which are very common, may relate to electrolyte disturbance, also are something that we need to worry about. Such disorders as Osgood-Schlatter's, with focal tenderness around the tibia, are also on the differential diagnosis. So we need to keep our differential diagnostic hat on and consider these other entities. But in terms of treatment for RLS, we start with the simple things: increased physical exercise, hot or cold packs, restricting caffeine, and potentially even treating any anemia with iron supplementation can improve these symptoms. Now, RLS, I'm trying to convince you, can be the nocturnal equivalent to attention deficit hyperactivity disorder. This work was started by Art Walters almost 20 years ago, but the statistics are there. The evidence-based medicine is there. Note that up to 44% of kids with attention deficit hyperactivity disorder may have restless leg syndrome, and up to 26% of kids with restless leg syndrome have attention deficit hyperactivity symptoms rather. So if the RLS is severe, then we obviously have to consider medications. Now, the first line of medications depends on the physician. However, gabapentin is a consideration. Benzodiazepines such as clonazepam are also another consideration. Finally, dopamine agonists such as ropinirole may be a consideration and has clearly shown efficacy in adults, although the literature in the pediatric population is still growing. Finally, for physicians and parents alike, it's important to remember what medications can worsen RLS. Antihistamines can worsen symptoms. Tranquilizers, we've talked about Haldol. Antidepressants such as Prozac or Paxil or Sertraline, or otherwise known as Zoloft. The anti-nausea medications, all of these drugs can worsen the RLS symptoms. So it's important to avoid these medications, or at least identify them. And this can be quite challenging when we're having a child who has significant anxiety, depression, and as well has some severe RLS. So let's move on to the next issue at hand, which is insomnia. We talked about behavioral insomnia being one of the most common disorders in childhood. But it's important to talk about what insomnia is. It's a difficulty initiating or maintaining sleep. Now, typically, we all have periods of insomnia when we're stressed and when we're ill. It typically lasts less than 4 weeks. But if we start to have this behavioral arousal and learned behavior that persists at around bedtime, and we start to learn that the bedroom is not a friendly place, but is a place that I have problems sleeping, then that acute insomnia can lead to chronic insomnia. Now, we still have options. We can send kids for relaxation therapy, cognitive behavioral therapy, but we have to realize and understand the link, the multifaceted link of insomnia. And it all goes back to that toddler and good sleep habits. So when the toddler starts to take the upper hand and parents fail to enforce a strict bedtime and not allow the child to learn to self-soothe, the child starts to associate this increased arousal, this bedtime resistance, these complaints, and getting their way as a reward in and of itself. And if that continues, then insomnia is the natural consequence. Now, parents are concerned. They should keep a sleep diary, and pediatricians may suggest a sleep diary or a referral to a sleep medicine physician. Now, as I said before, sleep medicine is multifactorial. And here's a graphic that shows the different factors, situational or precipitating factors. When we're dealing with the sleep environment, we need to understand what's the temperature. Is it not too cool, not too warm? Is there enough ambient light but not too much? Is my child on medications? Is my child passive or more strong-willed? Am I a poor limit setter? All these factors can impact and lead to poor sleep hygiene and insomnia. Now, for those parents who have children with attention deficit hyperactivity disorder or an adolescent with a phase delay, a trial of melatonin, which is a natural neurochemical, referred often as the, in quotations, dark hormone produced in the pineal gland, and promotes sleep, can be helpful. About 3 to 7 milligrams 45 minutes before bedtime may be helpful. And before we switch over to the parasomnias, I just want to reinforce that the basis for good sleep is good sleep habits or hygiene. Parents should keep regular bedtimes for sleeping awakening. The bed is only for sleep, so playing on the computer, texting in the bed, and that has to stop. Avoiding caffeine after 2 or 3. Making sure if the kids are coming back from swimming or they have to do swimming after 6 or 7, they may need more of a wind down, but if we can push the exercise earlier in the day, it may have a better impact in terms of their sleep profile. And overall, avoid stressful situations around bedtime will definitely improve the child's sleep profile. So the next sleep problem I want to talk about is parasomnia. This is something that we see it's very dramatic, and this is an episodic nocturnal problem where children may wake up, they look confused, they may look terrified, they typically look past their parent, their heart beats fast, they sweat. The more dramatic ones that we have to be aware of as physicians is the sleepwalking, because that has safety issues. But one that is often overlooked is the nightmare disorder, because there may be associated with that nightmare disorder some daytime fears or phobias and anxieties that are feeding into that nightmare. And so that's, again, the two sides of the behavioral coin. In addition of sleep parasomnia, which I've seen an increasing with the kind of burgeoning population of obese patients, is the sleep-related eating disorder. And I have a graphic or a video that I'm going to show you in just a bit. So sleepwalking or somnambulism is dangerous to the child. So that childproofing a room is important. Locking the windows and the doors, a use of an intercom device may be necessary. An overnight polysomnogram may help pick up the event, but it often doesn't, so that the parents and physician alike need to keep a high index of clinical suspicion. The other parasomnia is night terrors. This is, again, an arousal out of sleep that is associated with the child looking straight ahead, screaming at the top of their lungs, being unconsolable, and this may happen multiple times during the night. Typically, if it occurs too frequently, we can treat with clonazepam. Again, this typically disappears in adolescence. Finally, sleep-related eating disorder is an increasing concern as a parasomnia. Here we see a video of a 19-year-old female. She's obviously overweight or obese, and she is in sleep now. We don't have the EEG, but trust me that she's actually asleep. She reaches back for her bag, and she will grab, and typically the people with sleep-related eating disorder will grab a high-calorie snack, finish it quickly, and then resume sleep. The problem is that this has drastic consequences for worsening weight gain, worsening obesity, and of course, the more weight, the more likely to have sleep apnea. There you see her put the Snickers in her mouth and then put it back into the bag. So sleep apnea is the next sleep disorder that I want to talk about. It consists of the intermittent, partial, or complete obstruction of the airway that disrupts breathing at night. For children, it can occur in about 2 to 4%, but as I mentioned before, 20% of kids can snore, and that also can disrupt sleep. Sleep apnea exists on a spectrum. You see in this graphic, you can have a normal flow of air through the nares, around the glottis, and into the trachea, into the lungs. But any sort of increased tissue, narrowing of the airway, a big tongue, or the tongue sliding backwards can cause disruption and narrowing of the airway with the classic snoring. In severe cases, people actually will stop breathing and wake up gasping and choking. The causes for sleep apnea are many. As we get older, their muscle tone decreases. For some of us, our physiology, our jaws may be smaller. For others, yet, their tonsils are quite large. We call that enlarged tonsils. Tongue, again, for some reason the graphic is not coming up. We see in children with Down syndrome, for example, the tongue may be so large as to actually protrude or potentially fall back, both of which can lead to a worsening sleep or obstruction and sleep apnea. But anyway, the symptoms that we want to look at are both nocturnal and daytime. Snoring, nocturnal bedwetting, sweating are all indications, potential indications of sleep apnea. And over in the daytime, mouth breathing, morning headaches, weight problems, worsening weight gain, or even something as simple as chronic runny nose may suggest a daytime allergy, which is a risk factor for sleep apnea. So in the end, we again recognize that sleep apnea, like insomnia, like most of the sleep problems, is multifactorial, and that daytime sleepiness, because of the fragmented sleep, can lead to behavioral problems with low frustration tolerance, irritability, mood difficulty, and therefore a kid who's failing at school. And we definitely don't want that. So how do we diagnose this? Well, we first start history and a physical exam. And on that history, I recommend that physicians ask about a sleep schedule. And on the physical exam, to look for specific problems. A crowded airway, could be a large tongue, it could be tonsillar hypertrophy, meaning the enlarged tonsils, enlarged soft tissue in the nose called turbinate hypertrophy. A BMI is important. And looking for dysmorphic features, such as what we call retronaphia, or a jaw which is displaced posteriorly, such as we found in such neurodevelopmental problems like Pierre Robin, would be a red flag for physicians to order a polysomnogram. Now, a polysomnogram is the comprehensive overnight study to help diagnose sleep apnea. As we saw in this picture of the child who is hooked up for a polysomnogram, we see that there is an airflow to thermistor over the nose. He has EEG leads to frontal areas of the eye, the temporal lobes and parietal lobes of the brain. He has an EKG strapped here to get the heart rate, and bands around his abdomen to measure the respiratory flow and movements of respiratory muscles. Now, while a polysomnogram is not typically necessary to diagnose RLS, it is required for sleep apnea. And for those children who have more than 10 apneas or hypopneas per hour, the treatment option is surgery, and that specifically is tonsillectomy and adenoidectomy. It is considered the gold standard. Now, for a smaller number of children who don't succeed in curing their sleep disordered breathing with surgery, and those rates are typically high. Here in this graphic, we can see, all these numbers are a little bit old, that up to 94% of kids can be cured with tonsillectomy or adenoidectomy, or at least a relative improvement. The problem is that with time, the soft tissue does grow back. And so for the severe cases of kids who are refractory, who've had surgeries or multiple surgeries and still have severe sleep apnea, they may require stenting of the airway. And this is what we see in this graphic, where a continuous stream of air stents the airway open and allows the child to breathe. And again, this is only in severe cases, but may be necessary. So in summary, I want to review when it's important to talk to your doctor. And I want to convince you that if your child is having problems breathing, or the breathing is noisy, or there's snoring that's loud, or if the child is complaining of gasping or choking or waking up and their heart is racing, difficulty falling asleep or staying asleep, then they may consider seeing a physician, a primary care physician, and being referred to a trained sleep specialist. In conclusion, school-aged represents a time when children are open to education about sleep habits. So let's grab onto that time. Sleep deprivation can easily occur, but we can also solve the problem by doing a few things. One of the things is limit setting. Parents or caregivers can assist children in setting limits, establishing a regular sleep-wake cycle, a regular wind-down routine. It may be reading to your child. But other things are important. You have to say no to that caffeine. You have to take out those iPods and iPhones and the internet access. And that may just be one or two of the things that you need to do. But that limiting those limit-setting steps can help prevent disrupted sleep and improve your child's behavior. So in conclusion, I would just like to say that daytime behaviors and nighttime sleep problems are related. They're two sides of the same coin. Tourette's, attention deficit hyperactivity disorder, obsessive compulsive disorder, anxiety, although they're primarily associated with insomnia, you have to think about obstructive sleep apnea and other rhythmic movement disorders such as restless legs. If you treat the daytime behaviors, you can help sleep, and if you treat the sleep problems, you can help the daytime behaviors. But good sleep habits are the key. So in closing, I want to thank everyone for their attention. Sorry about the technical difficulties, and I want to wish everyone a good night's sleep.
Well, thank you, and thank you for all the great information. We do have quite a few questions, so I'm going to jump right into those, okay? I have a question about, let's see, a high school junior who does not tolerate the CPAP machine very well. He's exhausted, sleeping up to 18 hours per day. What are his options here?
Well, that's an excellent question. I think, it's very hard to do this in the abstract, but the first questions to ask anyone on a CPAP machine is how often they're using it. If they're not using it or they can't tolerate it, why? Often the complaints that I will hear is, it's blowing air around my nose and I can't, into my eyes, and my eyes are too dry. The mask doesn't fit, and I've got a bruise on my forehead. So those are issues which can be easily fixed by having a mask refitting. So understanding what kind of mask we're dealing with. Typically, full face masks may be optimal for some individuals and some children, but it may not be optimal for many others. The other issue is, what is the pressure? Is this an adequate pressure? Is it too much pressure? Is it not enough pressure? And so if the child has lost weight, or on the other side, if the child has gained too much weight, this may not be enough pressure.
Yeah, in this case, I will add that the comment is that he's lost about 30 pounds and still has some considerable more to go.
Right. So, I think that, one of the other things is to find out what's happening. Often what happens, I find out, is the kids are using their CPAP machine at night, but they come back, say they're, doing an after-school program, and they're napping, they're not using their machine. And they, if they're old enough, they may be putting on their machine, and because they're restless and moving around, they may knock the machine off. So in fact, even though, they put the machine on, during the sleep, they may knock it off. And so in fact, they're still having significant sleep apnea. They're not fully treated, and therefore, they're still experiencing that excessive daytime sleepiness.
Okay, so in that case, though, that child and parent should go back to their doctor, correct?
They need to go back to their doctor. They need to think about a mask fitting. They need to find out when the last CPAP trial was done. Was that the optimum pressure? Were there other considerations? But starting with the basics in terms of does the mask fit, and how compliant or how often the child is using it, and is it the right pressure, are the first 3 steps to consider.
Okay, thank you. I have a question from a parent whose child has TS, and they're asking, when do you know when it's TS versus a more complex sleep disorder? Is there, well, you've defined differences, but how do you, how can you make that kind of decision? Would the sleep study be the way to do that?
I would consider a sleep study. Now, classically, what we're taught is that typically tics disappear in sleep. The problem is that, as I was trying to show during this presentation, is that there are other rhythmic movements that occur, and that they may coexist. So it really almost doesn't matter. But asking about things like painful sensations or limb movement in sleep or restless sleep is when the child wakes up in the morning, are the blankets around their feet. Querying them about these sensory symptoms is important, because the child that we showed here actually had severe periodic limb movements as well as restless leg syndrome that complicated his sleep. And once we treated him for his restless leg syndrome, his sleep improved, and actually his daytime tics improved. And we didn't even change any of his daytime medications.
Okay. I have an example of a child who wakes up and goes to the bathroom in the middle of the night and then either goes to the parents' room and gets into bed and falls asleep with them, or falls asleep in the hallway and never makes it back to the bed. So the question is this sleepwalking? Like what? You know, what are they seeing here?
Right. And again, what's important to know is that there's no possible way of knowing without a polysomnogram. Why I say that is because it's important to be able to see the relationship of the behavior to the brain rhythm. And what I would say is this may in fact represent a partial arousal and a sleepwalking episode. But the reason for this may be because of some untreated sleep apnea. And the actual nocturnal bedwetting may be one of the clues here. So I would recommend, if a sleep study hasn't been obtained, to include a multiple muscle montage or parasomnia montage to get one to see if we can characterize that. And often the trick is to do it over several nights, and that will depend on the center, because obviously these sleep walking events or episodes don't necessarily occur every night.
Mm-hmm. And they might not necessarily occur if you're in strange surroundings either, correct?
And so those are the issues. So we have to have a high index of suspicion, and if there's any question, always kind of taking a video of your child, following them, not confronting them, but seeing, do they have purposeful behavior? Are they, doing things like going and sorting through their clothes or going to the fridge? And do they then come back to their bed? That can be very helpful as an initial kind of approach.
Okay, thank you. Are there any pharmacological interactions with melatonin and meds given for TS, such as Orep, Abilify? And secondly, what's the earliest age that's safe to give a child melatonin?
These are excellent questions. To answer the first question, there theoretically could be a interaction between melatonin, which is in the pathway for certain serotonin production, and Abilify. But I would say that would have to be at quite a high dose. So that while the theoretical possibility exists, a good physician needs to balance the use of these medications. Typically what I've seen is for children who have, let's say, very severe, let's say, vocal tics or rage attacks and are on something like an Abilify, we're also having some anxiety and maybe on a low dose of sertraline or Zoloft. These two serotonergic agents can interact and potentially cause a serotonergic syndrome. I think there's been a few case reports, but been unclear whether melatonin was the direct culprit. Definitely I would be very careful if the child is on other serotonergic agents or partial serotonergic agents in terms of the dose of melatonin, and may recommend a different drug. I'm sorry, what was the second part of the question?
The second part was, what's the earliest age that it's safe to give a child melatonin?
Right, that's a great question. I mean, there aren't great randomized controlled trials. I think that school age is safe. I would be weary of giving this medication in any child kind of younger than 5. I've had a few of my colleagues who work with children on the autism spectrum who have used this in children as young as 3. They typically go at a very lower dose without any untoward effects. For me, I kind of draw the line at school age. So depending on the severity and other issues, 5 or 6 years of age. But I have seen other clinicians use this at an earlier age. Now, I want to be clear that melatonin, although it is potentially a nice over-the-counter intervention, the usefulness for treating insomnia tends to disappear over several weeks and months. And so one has to be careful in having unreasonable expectations that this is going to continue to have the same effect in terms of improving the insomnia.
Okay, and would the tendency then to overdose in it then if it seems like
well, the
it's not
potential
working?
then is because then if the physician isn't aware to increase the dosage, 7 to high. I've seen some use as high as 10 or 12. I do not go that high. I limit to 7 milligrams. And again, the pharmacology doesn't necessarily make sense. So again, starting at the lowest dose and increasing very slowly and being aware of the other drugs that are on board and recognizing that these drugs do have some tolerance, even the over-the-counter drugs such as melatonin. And while it can be quite useful in the short term, it may not pan out. Now that doesn't mean that I don't have a very small number of individuals who continue to be on melatonin and continue to say that it works quite well, but they tend to be in the minority, and I think the evidence-based literature substantiates that.
What's that? Yeah, okay. I have a question about what would be considered unusual nighttime awakenings. I mean, do they fall into a particular category that those are the ones you have to watch for?
That's another excellent question. I think as a neurologist who also is on the watch for potential seizures, because some movements at night may suggest seizures, that any time someone has unusual behaviors that consist of shaking of either one limb or multiple limbs with incontinence, with tongue laceration, and that this one may have to consider that a seizure has taken place, especially if there's a history of risk factors such as febrile seizures, unprovoked seizures, a family history of developmental delay. Those are the kinds of risk factors that I look for in assessing whether I need to either get a sleep-deprived electroencephalogram study or EEG, or maybe refer for a longer video EEG to look at the brain waves.
Okay. I have a question about magnesium supplements. This individual says that they seem to help alleviate her RLS. Are you aware of anything in the literature that would support that?
Absolutely. Now, the literature, not so much for RLS, but for leg cramping. Okay. Vitamin E, magnesium oxide have been used with relative success in treating nocturnal leg cramps. So what I would suggest is if the person is getting help from magnesium supplements, to question the diagnosis. And that's not a bad thing. If your leg cramps can be quite severe and disabling, and if magnesium is working, then that's fantastic. But I would question whether this really truly is a restless leg syndrome or if this is rather a nocturnal leg cramps.
Okay, thank you. I have a question from a mom. Let's see. Her son has been on clonidine since he was a toddler. He has TSOCD, ADHD, and has lots of twitches and jerks in his legs and arms at night. Is there any hope that he can go to sleep on his own?
That's a question that parents ask me on a daily and weekly basis. The idea that the movements will stand in the way of sleep is a concern. And again, what we have to do is basically characterize what's going on. Everything that twitches, again, is not a tic. Everything that, as we said, we talked about seizures. And how do we treat them depends on what label we give them. And the only way to really assess that, I would say, would be to do a overnight diagnostic polysomnogram with what we refer to as a multiple muscle montage, which means several surface electrodes placed on the lower and upper extremities to characterize these movements and to determine what's going on. This addition will give a percentage of sleep efficiency, meaning how is the child falling asleep, how long does it take him to fall asleep, and are these movements getting in the way? If anyone remembers the previous picture of the young man with the movements, well, his sleep was severely impacted. After we began treating him for his RLS, his sleep improved, but he still had twitches and movements. However, his sleep dramatically improved, and he had a normal sleep efficiency of, I think it was around 93 to 95% on his last sleep study. So, yes, the answer is once we understand what we're dealing with and make the appropriate intervention, there's no doubt that children can sleep despite having these complex coexisting problems.
Okay, thank you. This mom says that she has 7.5-year-old twins, and they get about 10.5 hours of sleep each night, but yet they still seem to be completely fatigued by midday and seem to have moody behavior. It doesn't appear from what you've described as in your presentation that they have a sleep disorder. However, they really need naps, and on weekends will take as much as a 2-hour nap. And the mom wants to know if she needs to be concerned.
I'm sorry, could you repeat, how old are they?
7.5.
7.5.
And they have both been diagnosed with ADHD and a tic disorder.
Right.
And she wants to make sure she's not missing the bigger problem or a bigger problem.
Right. I mean, again, you know, the population-based studies suggest that ADHD it can be related to other problems such as narcolepsy or a disorder consisting of excessive sleepiness and sleep apnea. And I think both those are kind of not knowing more of the details would be on the differential. But kind of going back to you know, understanding basics. Yeah, definitely a 7-year-old should not necessarily be needing to nap. So the first thing would be to understand how much sleep they need. And they should be at least sleeping 11 hours. And if they're not sleeping 11 hours, then what you may be seeing is they're sleeping 9 hours and they're using their naps to get the catch-up sleep. If that's the case, then there's nothing to worry about. And again, 7 years old, when they're in either first or second grade, there are increased demands being placed. And the parents need to understand exactly what their sleep profile is like. And if there are other concerns, are the child snoring? Is there are these other issues of waking up with headaches? Are there this nocturnal bedwetting? If there's anything else to suggest any other risk factors for sleep apnea, then a diagnostic sleep study might be necessary. But again, I would start with the good sleep hygiene and assess how many hours they're sleeping, what their bedtime is, how long it's taken them to fall asleep, and their wake time. And through that, we can assess whether this really is a problem or whether you know, they're just catching up on sleep.
All right. I just want to say to everybody who's still online, we're coming to the end. So if anybody has to leave early, I would just encourage you to please complete the exit survey when you log off. And we're going to try and fit in a couple more questions here, okay? You're good, Doctor?
Absolutely.
Okay. This is a kind of a question that, you know, comes up with families a lot. And, you know, his son has TS, does not sleep well at night when he's alone. He wants to sleep in my room or sleep with his siblings. And how do you get him to sleep in his room? And you know, those questions come up. It doesn't matter what's going on necessarily with your child if they have nothing unusual going on. But it is a trick to get them to, you know, a tricky trick sometimes to get them to stay in their own room.
Absolutely. And so the first thing we do is I start from basics, which is, you know, to recognize that the child is, you know, growing up and they're to some degree, you know, trying to develop their own autonomy. If it's their bedroom, I try to make sure that they're finding their bedroom friendly. You know, some bedrooms you look at, the kids have so much stuff that they, you know, it's very uncomfortable for the child. And so, you know, making the bedroom a friendly place. Assuming that, you know, these issues are not a problem, that there's enough space and the temperature's fine and the lighting is sufficiently low, then I would get at the heart of what are the issues around sleeping. Is it worries or fears? And what are they fearful of? Is it fear of the dark? Is it fear of something under the covers? Is it something that they watched during the day? Understanding that is important, and allowing the child to understand that those fears are natural. And then what I introduce is referred to as a token economy, meaning I say, listen, my expectation as a parent is that you're a big person now. You're getting to be big. You're 7 or 8 years old, let's say, and we have to make sure that you sleep in your bed because it's good for you. You're not sleeping well if you sleep with mommy and daddy. So if you can sleep in your bed the whole night, then you're going to receive a token. And at the end of the week, if you have 3 out of the 4 tokens, you can have a toy that you want. And so what I use is a combination of a schedule with nightly tokens that can be then redeemed for smaller gifts or to maybe saved up for a larger gift or a trip. Can often work for children who are developing their own sense of what they want, their own reward system. It may be a video game, it may be a doll, a trip to the American Girls restaurant in New York. All those things can be used. And the more time you're spending with your child to find out, they want limits, they need limits, and they need to understand that you don't love them any less. And it's not that you don't want to be with them, but that they're going to suffer by sleeping with you and by not getting to bed and staying in their own bed.
Okay, and that's a tough deal to make sometimes, and
that is a tough deal. What I would say is we fight that fight, and we fight that fight, and I can speak from personal experience over and over again. And you will fail, and you will try again, and you will fail, and you will try again, but slowly you will make progress. But if you are having more of those struggles, then really taking the child to assess more of these fears and determine whether there's some underlying generalized worries or specific fears that they haven't vocalized, and talking to a counselor may be very important. So I don't want to leave that out of the picture.
And it doesn't matter much. I don't personally think that whether there's TS in the picture or not. I mean, it's just there are kids that do not sleep well and will not stay in their own beds.
Exactly, but for those kids who have, let's say, TS and OCD, and they have this kind of, I need to line my animals up. One of my dollies has to be in a bed, and each of my dollies has to be in a certain order. Those behaviors can get in the way of good sleep, and so allowing that to be, to some degree, part of the wind-down ritual, but to limit the ritual, still allows the child some autonomy, but also allows the parent to impose saying, this is, we can do this, but we have to stop here. And then you have to listen to me, and we have to get to bed. And if with enough of the kind of proper balance, this kind of equation can be successful. But as I said again, it's always a work in progress.
Okay, fair enough on that. I think on that note, we're going to wrap it up for tonight. Thank you very much, Dr. Seyffert, for your presentation. I think it was really informative.
Thank you very much for your patience.
Thank you for joining our webinar on sleep behavior. There is an exit survey which should show on your screen as you exit. Please fill out the evaluation on the exit survey. The discussion board is open excuse me, and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to the site. Our next presentation, trichotillomania, which is hair pulling, and other body-focused repetitive behaviors, presented by Dr. Martin Franklin, is scheduled for May 19th. This ends tonight's webinar. Thank you, Dr. Seyffert, for your presentation, and thank you, everyone, for attending. Good night.